Well, it's a pleasure to be here. So the talk of the lunch was that you've already heard one half of my household. Actually, it's 1/6 of my household, not counting the four-legged creatures. But here I am. I'm talking to you about, and I was asked to talk about health policy. But if we were to do that, we'd be here for ages. So I'm going to just talk about one point. And the point is that I want to talk about why it's important to evaluate healthcare programs. Healthcare programs grow out of health policy, and I think it's very important to evaluate these healthcare programs, and I'm going to motivate the importance of it in the example of Indiana Medicaid's home and community-based waiver program. That this waiver program is applicable to all states in the nation, and in Puerto Rico, where one of our doctoral students compared the home and community-based program in Puerto Rico to Indiana by way of showing how implementation may differ across regions. And then we're going to talk about whether or not this program is in fact meeting these issues of cost, access, and quality goals. So just generally for the students in the audience, we know that health policy refers to decisions and plans, specific plans, and actions that are undertaken to achieve specific healthcare goals within a society. And we're going to talk about the evolution of the Indiana Medicaid waiver program, and in fact it's the national waiver program, in the context of meeting specific healthcare goals. Most policy, and certainly the evaluation, should be considering cost, access, and quality. And so the question is how might we evaluate whether healthcare programs that grow out of policy are effective in terms of costs, really do ensure access to needed services, and are of high quality. So let's talk about long-term care. Who needs long-term care? Well, long-term care is intended for those who are chronically disabled in their ability to care for themselves. So nearly all long-term care recipients, 97%, require the help of another to carry out very basic activities of daily living. What are basic activities of daily living? Bathing, eating, dressing or grooming, toileting, and getting around inside or transferring out of a bed. And about 1 in 5 older adults, those aged 65 and older, have at least one disability in bathing or dressing or eating or getting around inside or toileting. It's so important that they have the help they need because successful and timely completion of these basic activities of daily living are needed for health and survival. And I quote my mentor, who was one of the founding fathers of the field of gerontology. So, how do people get help when they have a disability? Well, most rely on family and friends, principally on family, principally on female family members, principally on spouses or daughters. And when family and friends can't provide all the care they need, then they have to go to other forms of long-term care. Nursing home care, very expensive alternative, running about $70,000 a year. Assisted living, which is not as skilled in terms of the services provided as nursing home care, and they cost about $36,000 a year. These are average national costs. And then home health care, where somebody actually comes into one's home and provides services so that one can complete these basic activities, is quite expensive, running between about $22 an hour in some states to $35 an hour on average. It's about $29 an hour. Most are unable to afford long-term care. That's not surprising. Think of the generation who is now requiring long-term care and what their long-term benefits were, when they were working. So it's not surprising that most are unable to afford long-term care. And typically what happens is that people will spend down their capital until they have no capital left. And then they have to depend on some sort of federally or state-funded long-term care. So let's talk about the evolution of a long-term care policy. So long-term care is consuming about 1/3 of states' Medicaid budget. Used to be education was way at the top of budgets, and now it's not. Medicaid is right up there at the top of states' budgets. Why do we care as university employees? Because that means that state budgets are limited, right? And education can be affected. So we really have to consider how long-term care affects Medicaid budgets. And in fact, that's how I got into this program. Indiana Medicaid came to us at Purdue University and said, what can you do about this? And so that's how I began this program of inquiry. Nursing homes consume about 70% of Medicaid long-term care spending. The interesting thing about that is that 1/3 of nursing home residents are really capable of living at home, but instead they're living in a facility that is running about $70,000 a year on average, right? And the interesting thing is most older adults don't even want to live in a nursing home. They'd much rather prefer to live in their own homes rather than go to a nursing home for their long-term care needs. So there's clearly a public interest in finding alternatives to nursing home care for those who are disabled in their basic activities of daily living. The interesting thing is policy doesn't just evolve out of just need. Policy evolves also out of laws. And the American with Disabilities Act prohibits exclusion, segregation, and unequal treatment due to one's disability status. Well, how does that relate to older adults? Well, that means that we need alternatives to nursing home placement for older adults who have disabilities. An interesting thing is that the Olmstead decision also provides impetus for developing an alternative to nursing home placement. And the Olmstead decision said it is unjustifiable to isolate people in institutions. It is truly a violation of the American with Disabilities Act. And we know that that came down in the context of a different type of institutionalization, that for psychiatric care. But nonetheless, it's quite relevant to persons with just basic physical disabilities as well. And so home and community-based care services are an alternative to institutional care provided in a nursing home. And what happened is that nationally, home and community-based care was adopted as a model of care for persons with disabilities who preferred to stay in their home rather than go to an institution for their long-term care. And it meets Section 1915C of the Social Security Act. So we see that law has also influenced healthcare programming. Okay, so what is the home and community-based care program? So basically, federal government allowed state Medicaid agencies to administer what's called a 1915C waiver home and community-based service program. Okay, so they're allowing them to develop these what we call waiver programs. Now, I don't know how this verb turned into a noun, but nonetheless, a waiver program allows these states to administer services, long-term care services, in people's home without meeting all federal requirements. And one of those really important federal requirements that could not be met in the context of home and community-based services so far is that the services have to be equally available throughout the state. Now, in a state like Indiana, you can see why that's problematic, because we have some very rural regions in Indiana where it's just simply not feasible to provide home and community-based services to people for whom it would take, hours to drive there and hours to drive back just simply for a couple hours of services. These waiver services, waiver home and community-based services, are considered an alternative to nursing home services. And they're a mandatory benefit of all Medicaid eligible persons who require long-term care. So in other words, instead of always placing people who are eligible for long-term care in a nursing home, now we've got this alternative. And that's to be cared for in one's own home. Okay, so to be eligible, one must meet the same criteria as for nursing home placement, which means disability and activities of daily living. And it depends on the state how many disabilities one needs. To be disabled in bathing, dressing, eating, toileting, and getting around inside, that's fairly disabled. I'm not talking about vacuuming, I'm not talking about doing taxes, I'm not even talking about administering one's own medication. But to have one of these disabilities is fairly far along the disability scale. And some states require 2 disabilities and activities of daily living before they're eligible for paid receipt of long-term care. Now, there's several services that address activity of daily living disabilities. One is attendant care. That means somebody actually comes in and helps the person bathe, physically helps the person bathe or dress or eat. There's homemaking services, and as I've given lots of talks to people who run home-based services, they talk about the liquid lettuce in the refrigerator. You can imagine if someone is disabled in their ability to get around inside, they're not cleaning their home as they should, and we know that that's a health hazard. And then there's home-delivered meals, and while many people say, oh, well, our church gives meals, but the bottom line is that the Medicaid agency cannot depend on these organizations for constant delivery of home-based meals that meet the nutritional regulations for long-term care. So these are three types of services that can be delivered in people's home if they're eligible for Medicaid's home and community-based services. So they're disabled and also they're eligible for Medicaid, which means that they've met that financial level where they've spent down their assets and their yearly income is at poverty level, which is currently approximately $15,000 a year now. Now, even if somebody is meeting that $15,000 a year, one may also have to spend down that $15,000 a year on some of these services as well. So this isn't a big giveaway service for those who might be concerned about this. The wonderful black and white pictures in here were taken by a Vermonter who went around the state and took pictures of older adults in the state, and I wanted to recognize his excellent work. So I just want to tell you about this evaluation project. We were interested in are we meeting those goals of cost efficiency, of access to care and quality? And so we just wanted to compare these two groups of people. They're Medicaid patients. Some went into a nursing home, and some got to stay in their homes and get this home and community-based care service. And so that was the purpose of this evaluation. So what did we do? Well, first we had to get real data. And so we got real data from Indiana Family Social Services Agency. And it took you 2 years to do that. So these data are not super current. Okay? And what we did is we followed people forward in time. But the way we followed them forward in time is we had to say, there could be real big differences between people in a nursing home and people in home and community-based care services. There could be differences in acuity of illness and severity of disability. And so what we were really interested in is people who just immediately enrolled in the program, and those immediately enrolled either went to the nursing home or went to home and community-based care services. This is a naturalistic evaluation study. I didn't randomize them into these two conditions, okay? So they were all in the community. None had been waiting for months and months and months for this service. They are all in the community, and suddenly they start this service. We followed them forward 12 months in time. These people we studied were those with dementia. We know that they have some of the most complex care needs. And we then looked at inpatient rates and total adjusted expenditures. And they were adjusted for prior use, demographics. We know older people have greater expenditures, insurance status, and comorbidities, which could all contribute to costs. And so let me just tell you a little bit about these people. Not surprisingly, most were in the nursing home service, and few were in home care. Even though this program developed in the 70s, even by the mid-90s, only about 17% of persons eligible for nursing homes for long-term care, only about 17% were getting it in their home. The other 83% were getting it in nursing homes. So these figures are really not different, for Indiana versus other states in the nation. About half are older than 80, not surprisingly. Most are female. Women tend to outlive men at the end of life. Most are white. That is the demographics of the state of Indiana. And of course, very few are married. And so what we found that indeed nursing homes cost more than people who receive care in their homes. Not surprising. I mean, cost of room and board, it's coming out of their own pocket, right? The need for regulation for how much, for the meds and that sort of thing that is so costly in the nursing home industry is not there in the home and community-based care. I mean, obviously the providers have to meet criteria, but nonetheless, it's not surprising that costs of home and community-based care were less than half of those of nursing home care. But what really concerned me when my graduate student showed me this was this line. Costs were going up over time, and I said, we got to figure out what's going on there. And that's part of an evaluation research. What's going on? Tell me what's going on. So we looked, and interestingly, you see here the probability of inpatient service utilization. Fancy words for it, they went to the hospital. Okay? And the bottom line is that these nursing home people, the probability of their going into a hospital was not only lower than the home and community-based waiver patients, but it stayed low. Because a lot of illnesses that may emerge in the course of a year, such as a pneumonia or infection or something like that, can be taken care of in the nursing home. You know, dehydration after a flu can be taken care of in a nursing home. But the home and community-based care people, their probability of going into a hospital increased significantly over the year. Well, it nearly doubled, okay? So that really bothered me. Why were they going into the hospital? What was causing this? Was there any way that we could modify this in terms of program administration? So that led us to the next study. So we concluded that, in fact, they were meeting cost objectives, but the problem is I'm not sure that we could say that the quality objectives were being met. And so that was the conclusion of this first study. And so then we went on to see what aspect of home and community-based services could be associated with these patient outcomes. And I have to tell you that as an outcome researcher, I use pretty unarguable outcomes. Hospitalization, everybody knows, is a bad thing. You have to be admitted by a physician. You don't get to volunteer to go into the hospital, right? So we know that means that there's a level of illness that is such that it requires a hospitalization. We also know there's considerable health consequences of hospitalization. So that's what I'm interested in, is a patient outcome. What could be associated with this patient outcome? So we went and did another study, and we wanted to determine whether the volume of services these older adults were receiving was associated with hospitalization. What do you mean by volume of services? Well, if somebody comes in and helps you, does it matter if they come in 1 hour a week, or does it matter if they come in 5 hours a week? That's what I mean by volume of services. If you get home delivered meals, does it matter if you get 1 a day or 3 a day? Okay, so that's what I mean by is volume associated with future hospitalization. And nursing home placement, which is, in my book, not the most desirable outcome, because most older adults don't want to go to the nursing home, and we also know it's very expensive. All right, so this time, and because I had a different funding source, I didn't study just persons with dementia. So this study, we focused on anybody who got into the waiver service, and we followed them forward in time, 12 months, and we're using the Indiana Medicaid data, and we looked at time to admission, time to nursing home placement and enrollment, and again, we adjusted for all those factors that could contribute to those bad outcomes, okay? All right, so again, these are, they're older adults, and I just wanted to show you what was happening. Now, if we go to the second column from the left, it says the percent with greater than 8 hours of attendant care per month. So I'm going to do the math. 8 hours per month. That's about 2 hours a week. And only about half are getting more than 2 hours a week. And this is personal care. This is where they come in and help them bathe and toilet and dress. The percent, this is the middle column here, the percent with more than 5 hours of homemaking per month. Again, that's running about an hour a week. About a quarter are getting more than 5 hours. The percent with more than 11 home delivered meals, that's not even 1 a day. Okay? So the interesting thing is when we look at all services combined, 30% were not getting any personal care, 50% were never getting any homemaking or home delivered meals, and altogether about 20% weren't getting anything, but they were enrolled in the program, they had a plan of care, they were deemed eligible, they were deemed needy, and they weren't getting any of these services. Who would have known? This is, I'm trained as a statistician, I love pretty pictures. But the most important set of columns is the very most left one. You can see stacked boxes. Any box that's below 1 shows that the risk for hospitalization, if you're below 1, you're at lower risk. And the interesting thing is this box right here, the leftmost, frontmost box, reflects those who have 25 hours per month, about, let's talk about, 6 hours a week, all right, of personal care. And they have the lowest box. They're at the lowest risk of going into the hospital during that 12-month follow-up. Those with 15 hours a month have sort of medium risk. Those with 5 hours have lower risk than those with no hours of care. So my reference group was no hours of care. So compared to no hours of care, you're doing better if you have at least 5 hours per month. You're doing much better if you have 15, and you're doing much, much better if you're having 25 hours of care per month. Note that, in fact, the trend sort of equalizes after about 15 months in the program. And part of the reason why that is because we do expect change over time. We expect people's health to change over time, particularly for the people in this program, particularly for those with dementia or any other degenerative disease. Interestingly, there was really not a significant change in the amount of services received over this period by anyone, regardless of dementia status, regardless of illness status. They just weren't changing their plans of care. Nursing home placement. Also, in my book, a bad outcome, because most people don't want to go to a nursing home. Again, I'm mathy, so forgive me for a minute. Attendant care, that's the personal care. That's where somebody comes in and helps them bathe or dress. The hazard of going into a nursing home decreases by 5% for every 5 hours of care received. Okay? Same with homemaking and home-delivered meals. Don't get too caught up in the numbers. The reason why the hazard is lower here is only because homemaking was so rare. So just even having homemaking was tremendous for these people in terms of reducing the likelihood of going into a nursing home. So what did we learn from this second evaluation study? Compared to no care, 5 hours of attendant care decrease their hazard for going into the hospital, decrease their hazard for going into the nursing home placement. And interestingly, as hours of attendant care increase beyond 5 hours, the hazard for these outcomes decrease proportionately. And we found similar findings for other home-based services such as homemaking and home-delivered meals. Was this a perfect study? No. Evaluation studies are naturalistic studies. The data don't have that fidelity that can be achieved with really awesome data collection procedures that are typically articulated in federally funded research projects. So no, this wasn't a perfect study. We used analytic models that were driven by theoretical frameworks by Ron Anderson, who is a graduate of Purdue University. He's probably one of the most internationally respected health services researchers. And so we used his frameworks for adjusting for all the reasons why somebody would go into a nursing home or go into the hospital. But nonetheless, we know that we couldn't have controlled for all potential confounding factors, but we can say that the data have high face validity. These are Indiana Medicaid data from their recipients, from all recipients. No random sample, no nothing. This is from all their recipients. This is their data. I didn't manipulate it at all. And so they do have high face validity, and I think that they do reveal the need for further evaluation of the community-based service program. So here's my conclusion. Indiana waiver programs, it's only partially meeting the goals in terms of cost, because we know that hospitalization is costly. We know that nursing home placement is costly. Access, they're not getting enough services, and quality. And I would say in this case, the quality is just not getting enough services. And I think these evaluation results are really of interest both to clinicians and to policymakers. I think clinicians really need to be informed. Just because you've referred a patient to these services, it doesn't necessarily mean they're getting the services. And they need to be asked again and again. And that's a topic of a subsequent NIH grant I have. Just asking patients, do you have enough help? Turns out it's incredibly prognostic of hospitalization, a favorite outcome of mine, because everybody knows death, ED use, another expensive outcome, and transitions across the care settings, okay? So we know that it's okay to just simply ask, do you have enough help? And if they say no, then something probably not so good is going to happen in the future. So clinicians can use this information, but policymakers can really use this information to really be informed of the effectiveness of their programs and meeting the needs of beneficiaries, and whether there needs to be improvement in the efficiency in which these resources that they're allocating to these programs should be considered, and possibly, reprogramming so that those programs meet the goals of the policy. And that's all I had to say today for the
fascinating work, and I know nothing about this area, so I can ask a naive question.
Mm-hmm.
I was just struck by the chart that you had with the boxes that look like a little city.
Yeah,
You build up
the city boxes.
your statistic geek chart.
Yeah.
If you look at this and you put rather than just kind of hazard of hospitalization, but if you put like some economic parameters around it, because I assume for this demographic, a lot of hospitalization costs are societal costs as opposed to individual costs. I'm guessing that that's the case. Maybe this is implicit in what you've done, but doesn't this make the case that, throwing more money into the various forms of home health care, right, if you assume that there's a causal relationship, makes tons of sense? Right, and it would be cheaper for society all along to kind of help people avoid the hospitalization event, and that your data would seem to suggest that there's pretty good evidence that that would be the case. Is that, did I interpret that right, or?
So I'm going to give you a yes, but you're absolutely right. I can't assume causality. This wasn't a randomized control trial, and so these are just associations, right. And we have a lot more to learn. And we're NIH still funding qualitative studies where I could actually go in and do in-depth interviews, like hours of interviews with clients from area agencies on agent. I'd do it in a flash, but that's not where the funding is anymore. So I don't really know all the reasons why they're not getting the services, and that may be confounding this relationship. So I will admit to that. I will now tell you a funny story. I did give this talk recently for the Myra Samuels Memorial Lecture in the Department of Statistics. And one of the professors said, you sound like a health economist. And I said, what? And I said, you mean I'm a healthy communist? Is that what you said? And he said, no, a health economist. And so that too, I am not. I am not a health economist. They would have much more elegant ways of modeling cost than I did, but we did control for those what Ron Anderson, a Purdue graduate, called predisposing, enabling, and need factors that contribute to utilization of healthcare services. Yes, absolutely.
Have you measured morbidity rates based on the two options?
And so,
in other words, did the morbidity rates go up for home care and community care versus nursing home care?
Yeah, and so when we talk about morbidity rates, when we're using claims data, we are limited to claims as a way of determining rates of morbidity. And we know that claims are not the most sensitive indicators of morbidity. We know they're specific. That's when somebody does have a claim for something, they did have it. Right? But they're not very sensitive. For example, a patient comes in with diabetes and their glucose is high. They come in with arrhythmia and that has to be fixed immediately, and they come in with dementia. How is that visit going to be coded? Well, according to DRGs, diagnostic related groups, it's going to be coded according to that diagnosis, which was the most expensive to treat. And so we may not know if a person has dementia because of their weekly visits, because they may not code for dementia, okay? They'll code for the other thing, the ear infection, the arrhythmia, the whatever else they have, okay? So when we look in claims data for the presence of comorbidity, we have to look backwards and forwards to pick up some of those more long-term diagnoses. And so with regards to being able to do surveillance of morbidity, I'm kind of at a loss with these data, and particularly because I looked at only one state. As I look at Medicare data, and I have a national probability sample in which I've linked their survey data with that, I'm doing better at understanding, being able to survey comorbidities over time. So again, another limitation of my evaluation study.
If Indiana decides to expand its participation in Medicaid under Obamacare provisions, how do you think that would affect the home care-based programs and the data you found?
It wasn't really that, and I'm not going to pretend I know what's going on at the state level. I read in the newspaper a little something today, and I was just frustrated because it was too little to really understand what they're thinking. But you have to understand that most of that was really not directed at the long-term care issues. And in fact, a lot of people have talked, yay, nay, whatever about the Affordable Care Act, but I did want you to know that there was a provision in the Affordable Care Act for long-term care, and it was subsequently taken out before it was signed into law, and that was called the Class Act, but it's out because it was considered economically unfeasible. Yeah, so we've got a lot of work to do with regards to long-term care and how we program it so that it's efficient and effective. I would agree with your conclusion. Yes.
Have you thought about what the results might imply about care prior to month 1 and just deferred or non-existent, given the group of people that we're talking about, and then therefore what that might imply about maybe about Obamacare or maybe about other sorts of programs?
I can answer that question, and it's actually published in a journal in 2006 in the Journal of the American Geriatric Society. So there's a lot of long-term demonstration programs that are out there right now, and some of those demonstrations then are shown to be effective, and then they actually get adopted into practice. And one of them is called PACE, the Program of Acute Care for Elders. And basically it says everybody who goes into this program signs over their insurance status, Medicaid and Medicare, to the PACE program, and they provide all-inclusive care. And so what I did is I looked, because I had the demonstration data, I looked forward in time. So before they got into PACE, they simply were asked, do you have someone at home to help you care for yourself, for your disabilities? Do you have a caregiver? Is there someone there? And the interesting thing is that those who did not have a caregiver had hospitalization rates once they got into PACE that were twice as high as those who had the care they needed at home, but were using PACE as really a facility for obtaining, primary care, outpatient care, if you will. 6 weeks after being in PACE, the hospitalization rates of those who didn't have the care they needed at home went all the way down to the same level as those who did have the care they needed in their homes. So is care effective? Again, observational study. I didn't randomize them to, you don't get any care for a year, but you can have care. In fact, there was a commentary on my article saying how unethical it was that I allowed these people not to have care, not knowing that I got the data subsequent. Okay, but the bottom line is yes, care appears to be effective in reducing these rates of hospitalization.
That's what that shows me.
Yeah, and so, yes, but again, that was prospective, and the one that's in that journal, JAGS, was retrospective. So once they got the care they needed, then in fact their rates of hospitalization went down. Yeah, I think care is a good thing.